Welcome, everyone. Thank you so much for joining us today for today's webinar, which is entitled Simplifying Your Referral Capture Solution. My name is Kylie Savage, and I'm a part of the SpendMen marketing team, and I will be introducing our excellent expert speakers, Riley Protz and Rob Nahupi. We will be diving deeper into the intros in a moment, but here are a couple housekeeping items that I would like to go over. This webinar is going to be a 60-minute presentation, which includes a 15 to 20-minute Q&A at the end. On your screen, there is a GoToWebinar panel somewhere where you can go ahead and type out any questions that you would like to ask our speakers. We absolutely welcome any questions or comments, and we will go over as many as possible during the Q&A, depending on our time. Any questions not covered during the Q&A will be posted on our SpendMen LinkedIn next week, so make sure to check that out. Another item that I'd like to cover is that you will be able to do this, watch this webinar again. This presentation will be sent out in an email with a link to the webinar for downloadable slides. So make sure you keep an eye out for that follow-up email again. With that being said, let's go over the introduction for our expert speakers. So first we have Rob. Rob is a frontline 340B expert with experience as a regional director within the pharmacy of a 22 hospital health system. His responsibilities include regional oversight and direct responsibility for 395-bed Dish Hospital, in-house community pharmacy, and contract pharmacy arrangements. For the last 9 years, he has been providing 340B external independent audits and the 340B gap analysis for 340B covered entities across the country through his role as CEO of Turnkey Pharmacy Solutions. After the Turnkey acquisition by SpendMen as SVP of Pharmacy Services. Thank you so much for being here, Rob.
Thanks, Kylie.
And next we have Riley. Riley is a director of optimization for SpendMen pharmacy team. Most recently, Riley has served as a 340B program manager and pharmacy inventory manager for over a 500-bed Dish and CA. During his time, Riley established a centralized 340B team and oversaw the expansion of the 340B program, resulting in significant savings and increased program compliance. He has also presented at 340B Coalition regarding the program strategies. Thank you for being here, Riley.
Thanks, Kylie.
And with that being said, I'm going to hand over the rest of the presentation to Riley and Rob, and I'll be back at the end to walk us through our Q&A. But for now, I will leave it to the speakers.
Excellent. Thank you, Kylie. So first, we'll start with the typical disclosure statement. Neither Riley or I really have any conflicts of interest, other than we do work for SpendMen and we are 340B consultants in the space. But really, our goal today is really to educate and share more information, everything we've learned on referral capture. You know, we definitely think it's an area that can help covered entities, especially those that are impacted by the manufacturers who have taken away pricing in the contract pharmacy space. And as we talk to a lot of our clients and covered entities, there is this idea of, well, how do we recoup, some of these losses? It's impacting our bottom line. It's impacting our ability to take care of patients. So hopefully, if you're not already doing referral capture, or if you are doing referral capture, if you're thinking about doing referral capture, this will be a helpful webinar today. So we can go to the next slide there. So first thing we like to do is just go over objectives. And so, Riley and I are both residency trained pharmacists, and so we can't help ourselves. So we have our residency kind of base objectives like you would for any presentation. So hopefully by the end of this presentation, you'll be able to do the following. You'll be able to maintain compliance if or when you implement a referral capture solution, that you'll be able to utilize analytical tools to assess your referral capture savings opportunities, and then finally, to really be able to list the developments around the 340B patient definition and the impact to referral capture. So that third one's a little bit of a hint that by the end, we hope to cover some of those gray area things. We've been putting out some information about 340B patient definition and how it could apply to you. So hopefully that'll be very helpful as we start getting into that subject as well. And we'll talk about a future opportunity to learn more about that we have coming up here in July. So next slide there. So first, let's get into what is referral capture. And I think to start off with, we'd love to have a poll. I think what's helpful for Riley and I is if we can understand kind of what our audience is going through right now with regarding referral capture. So please, if you're in the process and if you're a covered entity, if you could answer the following question: who is currently using a referral capture service? And so options are: one, you're doing referral capture and you have an internal process. So you have a team that's capturing these right now. Or two, maybe you're using an external firm to help you identify and capture referral capture. Three, you're not in the process of referral capture, but you are looking at it as an opportunity. Or four, you don't have a current process and you're not really thinking about it as an opportunity. And there could be various reasons why you're not looking at it. And then finally, maybe you're here because you have no idea what referral capture is. We put it out there and you're like, okay, let's go figure out what this referral capture thing is. So that's option number 5. So we'll just wait for some of these results to come in and then we'll share them live. I love these quick polls because you get to see the results in person, and it'll help Riley and I understand kind of what the audience makeup is today.
And I'll add, it's probably helpful for, really everybody. If you something internal, hopefully some takeaways for, something that can help you optimize what you're currently doing. And if you're thinking about doing it, then hopefully we can tell you, help guide you to say if the decision is yes to move forward or no, maybe you don't want to move forward.
Okay. Well, so results are in. So what we have is, so the number 1 group represented today is no current process, but are thinking that there is an opportunity. So that's 45%. Riley's got a lot of good content coming up where he'll share kind of how you assess that opportunity. And I'll be upfront. Riley leads referral capture for us within Spendman. He's also a director of optimization. So he's done a lot of work with a lot of covered entities and not only assessing the opportunity, helping with ESP programs and everything else. So he'll be excellent today. The second largest group represented is you do referral capture and you have an internal process. So, just maybe to learn more today. And then about tied is we use either an external company at 9% and also I don't know what referral capture is 10%. So fantastic. Hopefully by the end you know what referral capture is and if it's right for you. And then finally, we have a 3% that doesn't have a process and aren't really thinking about it as an opportunity, and maybe it's to confirm if it's an opportunity or not. And one good example is if you don't really have primary care clinics, the opportunity is definitely a lot less. But hold on if that's you, because when we get to the end, we'll talk about this expanded patient care definition a little, and definitely point you in the right direction to learn more from a white paper we have and a future webinar we have coming up on this subject. That maybe even if you don't have those primary care clinics that traditionally mean referral capture is an opportunity, you still have an opportunity if you decide to kind of use a patient definition expansion process. So wonderful, thank you for participating in that poll. So first, let's go to the next slide there. Okay, so let's talk about the core or the key to referral capture. It's all around the patient definition and maintaining responsibility for care. So I kind of already alluded to, we normally see referral capture as a process that's utilized when you have qualified 340B primary care clinics. So it's whether you're an FQHC, whether you're a critical access hospital with rural health clinics, or you're a larger hospital with, again, family practice, or you could have a variety of other ambulatory care providers. And sometimes that gets expanded. Internal medicine is a real common one, but we even see OBGYN, oncology, HIV, or infectious disease. These are all areas that you could potentially have be treating patients kind of on a longitudinal primary care basis. But the key here is that you are responsible for care. So that's a key part of maintaining 340B compliance. And so if you look at the patient definition, this is the 340B patient definition. We've kind of got it down there below that the covered entity has established a relationship with the individual such that the covered entity maintains records of the individual's healthcare. So again, having that some kind of visit that qualifies the patient, especially in a primary care situation. Second, and this is the interesting part, people always ask, well, where did this referral thing come from? It actually came from the patient definition. If you read that whole final one on the bottom right corner, it's the individual receives healthcare services from a healthcare professional who is either employed by the covered entity or provides healthcare under contractual or other arrangement. So this other arrangement, it's been interesting, but HRSA has given us this other arrangement example. Remember, E.G. comma, sorry, I'm totally getting nerdy about this, is for example. So it's not an all-inclusive list. That would be I.E. comma. That would be an all-inclusive list. Sorry, Riley, he's already shaking his head at me for this. I've got this issue with I.E.G. And those that know me already know this. But so referral for consultation is one example. And so that's where it comes from. And then, but this last part's critical, such that responsibility for care provided remains with the covered entity. So again, that's why if you're a primary care provider or you have a qualified clinic, that's really the quarterback for care. They have general responsibility for care, even when it refers out to the specialist. There's just some I's you should dot and some T's to cross. So we'll go to the next slide there, Riley. So hopefully that's helpful in understanding where it came from and really what we're talking about around patient definition. So how does it work? So first of all, this really what happens is, the patient's seen in your covered entity, and the patient's referred to an outside provider. So this outside non-qualified provider. the patient sees that provider and gets a prescription. Now, this provider could be a non-qualified 340B clinic, so normally nothing they write would qualify, no prescriptions they write would qualify. And the patient fills it at a contract pharmacy. They could fill it at your own in-house retail pharmacy too. And then the way referral capture works is then, we talked about internal or external, but your employee or a firm takes all that data and matches it and says, oh, that patient was referred to that clinic. And so then looking at all that data, then we can capture that and make sure that the covered entity has responsibility for care. And then someone, either the employee or the consultant, then manually moves that prescription from unqualified to qualified within the third-party administration system. So lots of different systems. Some are easier than others to use. Some have review queues or pending queues that you can work that already have this information in there. Some are a bigger manual process. But in general, that's how referral capture works. It's a sort of a manual process. It's very hard to do this automated, which is one reason we're having this webinar, is kind of talk about what you really need to have in place if you're going to take this on internally, or what to look for in a compliant vendor who's going to do it for you. So we'll go to the next slide there. Okay, so assessing opportunity. I'm going to hand this over to my esteemed colleague Riley, who will cover the next few slides for us.
Thank you. Thanks, Rob. I think it's really great to go over. One of the main concerns I get when I talk to people who want to implement referral capture is compliance. Like, how do I ensure it's going to be compliant? And I'm glad you hammered the point where it's written in the patient definition. Like, they even have the example there for you. And then question number 2 I always get is, okay, well, how does it actually work? And so it's going to be different for everybody, but those 6 steps are kind of the main steps for how you would go about implementing a referral capture solution. I'm going to step back a little bit and talk about contract pharmacy solutions and just contract pharmacy as a whole, and kind of my philosophy on, if I get asked, how would I increase my savings? Most or everybody has been impacted and has seen decreased savings due to the manufacturer blocks. And so when your question is, well, how can I get back to where I was before? We're really taking some financial losses. My answer is, well, there's really 2 buckets and 2 solutions you can look into. And so I have a very simple equation here. Eligible prescriptions plus contract pharmacies equals 340B contract pharmacy savings. And I'm going to use an analogy here of throwing darts at a dartboard to kind of explain my thought process. So I'll start with eligible prescriptions. Of course, these are your prescriptions that are being sent out to the contract pharmacies. So coming from eligible locations, these could be discharge scripts, primary care prescriptions at an eligible child site, and whatnot. If your goal is to increase your number of eligible prescriptions, most likely it's going to be an operationally complex solution. Let's say you need you want to implement another child site or add-on clinics or a child site hospital, whatever it may be. A lot of times this requires external stakeholders, will take a lot of time, minimum 6 months, etc., where you're going to involve finance and executive leadership. And so it's a great solution, but it's not something you can do right away. And then moving next to the contract pharmacies, I think this one makes more sense to probably most people listening who've either been engaged with terminating or adding contract pharmacy agreements. Not as difficult, not as complex. Generally, you can keep this internally within the 340B team. Maybe you can involve someone from data who's going to send out data feeds and whatnot. Of course, there's a time element as well. You have to wait another quarter before registering and going live, etc. So not as difficult and complex as the first bucket, but still, there's some timeline involved in this. And when I talk about the complexity and the time involved with both of those solutions, because I know people want to see savings, they want to see them quickly. And so that's where I think referral capture becomes the most effective, because for a lot of folks, I think that especially if you're already thinking about doing referral capture, that means you think there is some opportunity. You could, feasibly start doing this tomorrow or next week, because the nature of how referral capture works is, you already have eligible prescriptions, let's say from primary care. They're already seeing the specialist. That prescription was already written from the specialist. You already have that contract pharmacy agreement in place. And so all you're really doing is on the back end doing an auditing and manual qualification of that claim. And so if you're trying to justify and present this to leadership and say, hey, I think I want to implement this solution, I think it's not a hard sell, because it doesn't take that much time and doesn't involve a lot of external stakeholders, which I think is really great. So of course, your referral capture prescriptions is your darts, the eligible prescriptions that you're throwing at the dartboard. So thinking about, the more eligible prescriptions you have, the more darts you're going to throw, the more times it'll hit, and the more 340B savings you'll achieve. Manufacturer blocks, of course, is when you're removing those darts from the dartboard because these NDCs are being blocked. And on your contract pharmacy side, I'm thinking this is, you're increasing the size of your dartboard. You're capturing more savings from prescriptions that are already being thrown. And so as you increase the size, as you claim more, hopefully you'll have increased savings. I know some people with the manufacturer blocks have actually had to reduce the size of their dartboard because the way that their agreement works with the contract pharmacy, it's actually losing them money. But ideally, if you're adding a contract pharmacy agreement, you're capturing more claims, you're seeing more savings. I'm going to step back a little bit to these manufacturer blocks because I think this wouldn't be a discussion around contract pharmacy if we didn't talk about the manufacturer blocks and what's going on. And Rob mentioned that people are looking into referral capture because it's a solution to mitigate those losses you're seeing from referral capture. But I think it's not a mutually exclusive situation, unfortunately. Just from doing my own work with referral capture, my own internal auditing of clients, a lot of these referred claims, just think about who your specialists are. They're your cardiologist, your dermatologist, rheumatologist, gastroenterologist are probably your main 4 or 5 groups. Unfortunately, majority of those claims that they're prescribing are made by these manufacturers that are blocking your claims, and so they go hand in hand. And one of the things that I recommend, if you probably already have made a decision around what to do with manufacturer blocks at this point. If you haven't, I strongly encourage you to do so. Either designate a single pharmacy if you can to those manufacturers that you're able to, and if you've made the decision to submit data to ESP, if you have not, I think make that choice, and you have your pros and cons from each side. Referral capture is just going to change that equation a little bit. Maybe it'll incentivize you more to designate a pharmacy or submit data because they will work in conjunction with each other, if that makes sense. I think that steps us next to our second and last poll question. Everyone is curious, what is everybody else doing with around ESP and submitting data? And so, Rob, you want to take us through that question? We can get an answer from everybody.
Absolutely. So this is the same poll we've done. We did our initial ESP webinar back in January, with Jake, and we had a couple of our clients on that one, which it was fantastic. We have it recorded. If you haven't been able to watch that one, Jake and I did an update on savings and asked the same poll back in, I want to say May or April. I'm losing track of time. I can't believe we're almost in the second half of the year already. But please, if you're a covered entity, please go ahead and answer this question. You got 3 options. And again, we want to get a pulse check. What are you doing as a covered entity regarding the 340B ESP program? So 3 options. 1, you enrolled a pharmacy, so a single contract pharmacy per manufacturer, but are not submitting claims, right? So that's number 1. Just so you're using a single pharmacy exception. Maybe rolled into that would also be health system owned exceptions. Second, a little bit further down that line is you decided to submit data on at least 1 manufacturer. So you're officially submitting data to get more than 1 of your contract pharmacies back in play with the manufacturers. Or 3, you've decided not to interact with the ESP program at this point in time. So you haven't selected a single contract pharmacy exception, or you haven't you haven't sent data. And so we'll just wait for the results to come back in. And I will say one thing, working with Riley, again, I kind of mentioned Riley leads our referral capture solution along with optimization. He also helps, he manages our management clients. So he's done some really good work on this. And one thing that we've looked at is, especially when you have multiple contract pharmacies, sometimes it's, you do have to kind of look at your data by manufacturer. And what Riley identified for one of our clients was, you know what, there's 2 major contract pharmacies that contribute to the bulk of the information. So our bulk of the savings per manufacturer. So about half of them went to one pharmacy and half of the manufacturers went to the other. So don't assume because one of your pharmacies, your contract pharmacies, are the busiest that you should pick that one. You really want to take a little bit of time and use the data by manufacturer. You can use labeler codes by splicing out those first 5 digits of the NDC and really identify which ones which has your best savings, because you could really optimize your savings by looking at the stores individually by manufacturer. So having said that, the data's back in. So interesting. Okay, so enrolled a pharmacy but have not submitted qualified claims. So this is single contract pharmacies, only 23%. This number is bigger than I expected. So those submitting data to the ESP program is now at 38%, which is exactly tied with no interaction with the 340B ESP. So I'm trying to do quick math. That means 61. If you guys are adding the math together, it doesn't even add up due to rounding. 62% are engaged in 340B ESP with 38% sending data. So for those that are wondering, what are my other covered entity counterparts doing? So we're getting close to 40%. We actually anticipate 40 to 50% by the end of Q2. So we were close, so not quite as high. That could be, now we like to talk about the fact that those on this webinar might be a disproportionate share of hospitals that would do it because you have a bigger contract pharmacy network opposed to hospitals and FQHCs who maybe don't have as big of a contract pharmacy network where it wouldn't apply. But again, 38% still not interacting today. So pretty big numbers, Riley. I'm not sure what your thoughts are on that.
Yeah, I think we were expecting more people than 2 months ago to have submitted data. I think just over time, especially as April and May hit, our last couple big manufacturers, J&J, GSK, blocking the beginning of May. Then now we're finally seeing the May and June data. So I think it's always going to be 2 months delayed, and so maybe later in the summer people are like, oh wow, those recent blocks are going to hit us really hard. So maybe we'll see it climb, and then I'm thinking it's going to level off until there's more manufacturers, right? I don't expect it to end. But yeah, I mean, I am surprised to see the number of people that have not engaged yet. It depends on how your program configuration is, and if you have most of your patients are going to your in-house hospital and retail pharmacy, then there's less need to do so. But if you're still waffling on making that decision, I definitely recommend making a decision of at least designating the pharmacies. There's I think little risk and a lot of financial savings to be achieved there.
Yeah, and I should share for sending data to the ESP program, and when Jake did the first webinar in late January, almost February, just before I think the coalition conference, it was about 10% were sending data to the ESP program. When Jake and I did the webinar 2 months ago, it was 20%. So we've almost seen it doubling every time. I'll make a prediction: it's not going to double again by the next if we ask the same claim, because that would be 76% if I'm not doing bad math. And so I don't think it'll get that high, hopefully, but that is a significant increase. So hopefully it's helpful for everyone who's still on the fence, deciding what you want to do and seeing what other people are doing. All right, we'll continue with the webinar.
Yeah, I think we'll probably have the same question again in 2 months at the next webinar. I think it's going to remain a hot topic for the foreseeable future
until it gets fixed. Absolutely. Okay.
All right.
So slides back up there.
Wait, can you see my slide?
Nope. If you would, yeah, I think you got to share them again.
Oh, I'm sharing screen. Can we?
There we go. Okay, we're back.
Okay, yep. Cool. All righty. So I think I forgot the results of the first poll, but around 45% of folks have not made a decision on if they want to do referral capture. And so it's like, okay, how do I assess that opportunity? And I think that there's two categories of how to assess your opportunity. One is diving into the data and actually getting a financial assessment, a number, some sort of estimation. And the second strategy is the more simple strategy. And those are for, I think, the people that, maybe higher level are just thinking, is this, let's go or no go? Do we want to make a decision to move forward and spend some resources into an assessment? Or is this opportunity to say, you know what, at the end of this webinar, don't have to think about it again. We're fine with, knowing that referral capture is not for us. And so I'm hoping that we can go through this exercise now and just looking at program configuration. I've put 3 different categories here. I know everybody's different, so you're probably not going to fall into those 3 buckets exactly. But I think it's a good exercise just to say, okay, who has the most opportunity, some opportunity, and least amount of opportunity. So starting at the top, let's say tier 1, those who have eligible primary care services. And so that can be very different. That could be, let's say a DISH or a critical access hospital who has their medical group as an eligible child sites, maybe FQHC or other clinic who has primary care services. So you have primary care that's eligible, and you have a large contract pharmacy network already in place. So you've already contracted with your local chains and independents, maybe a couple specialty pharmacy agreements already in place and mail order. I think that's important, and I'll dive into the next slide when we look at the data. Having that contract pharmacy network is in place because then you have access to the data to know what is not qualifying. If you don't have the contract pharmacy agreements, then what I say is you don't know what you don't know, right? So it's hard to make an assessment if you have no idea what's actually being written, because these are not your claims, and so you can't look at like e-prescribe data a lot of the time because they're not your providers. So if you are tier 1, I think now I'd say I strongly recommend doing something internally with referral capture. At least if this is not enough of a reason, do some sort of estimate and say, okay, what is our potential savings? Or just dive in and just see. Like I mentioned before, there's a little work and time risk. It doesn't take a lot to implement. At least try it out. It's just additional auditing on your end. If you can find those claims, which I will tell you becomes the difficult part. So if you're tier 1, I strongly recommend doing so. And Rob will get into this a little bit later, but I think time is of the essence, and we can explain why in a couple slides. Tier 2, so you'll see there's a theme here. Eligible primary care is your main component. That's the best argument for having responsibility of care. But if you also have eligible specialty services, so I think of your larger health systems who have eligible child sites of your cardiologist and your rheumatologist, et cetera. So if you by definition, you already have these as eligible locations. These are already hopefully eligible prescriptions. Your TPA, knows that those are the correct providers and is matching those provider NPIs. And so there's less need to implement referral capture because you should already be capturing these. I put that still as opportunity though, because you're likely not going to keep 100% of your patients within network. And so there's definitely patients are going elsewhere to see providers. So, and again, you already have, a lot of the processes already in place. Second here in category 2 is primary care, but you have a small contract pharmacy network. And so there's a couple of strategies I think if you're in this group on what to do. Like I mentioned, you have that question mark because you don't know, if you ask me like should I get more agreements in place with contract pharmacies, and I'm gonna tell you, well, you don't know if you should because you don't know what the benefit's going to be. Possibly you're somebody who had contract pharmacy agreements in place, you actually terminated them over the last 12 months because due to the manufacturer blocks, you've lost savings. It's possible that your cost versus benefit analysis will sway towards maybe bringing them back if you're doing referral capture. What I would recommend is doing more of a tiered approach. Start doing it with your current contract pharmacy agreements. So your current small contract pharmacy network, see what your savings is per month, moving forward, and then put a prediction on, okay, well, due to the size of the pharmacy that I'm working with now and claims I see, what could my benefit be if I added those agreements back again? And then category 3 here, I put bronze. It's possibly the folks where it's maybe don't move forward with referral capture. It depends on obviously the build of each covered entity. But if you only have hospital referrals, so I think there's 2 reasons why referral capture may not make as much sense. One is just sheer volume. I've done this assessment in the past, looking at hospital referrals. Epic is, as an EMR, has the ability to look at, what is being sent out as referrals. There just wasn't a lot there to, implement a process for auditing of those claims. And then secondly, for compliance reasons, your argument is you want to show that you have responsibility of care, and there's just less of an argument there as your primary care. If this patient came to the ED one time and saw the provider, and then a prescription, they referred someone and a prescription was written 10 months later, are you really showing that you have responsibility of care of that patient's diabetes, etc. Rob, feel free to jump in if you have anything there.
No, I love the gold, silver, bronze, and the bronze. I'll be honest, if I should pull up to my mic here, but if you're on that third category where you don't really have a lot of primary care, no contract pharmacies, maybe you're an in-house retail pharmacy, you probably already know you don't have a ton. So we'll definitely get into options for you there, and we probably won't get into a ton of that. Probably offer a different webinar, but we'll talk a little bit. Don't count yourself out, but do realize it really is those ambulatory care and especially primary care services that really drives the volume in this space. But no, it's a good call. I think for sure if you're in that gold tier 1, definitely something you should be doing. Unless you say, gosh, you know what, Rob, we're doing so well financially as an organization, we don't really need to find any more savings. We meet very few covered entities that are in that bucket, but some people say, gosh, we're doing okay right now, but I can't imagine that everyone is with everything going on with manufacturers and everything else. So I definitely totally in line with Riley sharing today.
I have not met anybody yet who says, no, I don't want to see more savings, but I guess someone could be out there. Alrighty, and then the last one here I didn't touch on, but if you have no contract pharmacies, of course, that's the biggest question mark. You have no idea, even what your contract pharmacy savings would be without referral capture. So it just becomes, if you've already made the decision to not have contract pharmacies, I doubt adding referral capture is enough to push you over the edge to add them on. Right, so I think, most people, if they're on this call, they're within 340B world, they want to look at the data and they want to do an actual analysis and they want to have some sort of projected estimate savings, maybe by month. And that's understandable, of course. Let's say if you have to justify adding half an FTE or 1 FTE to executive leadership, you need to produce, okay, what could that estimated savings be? Because if you're just adding on labor, they're going to say, no, that doesn't make any sense. So this is where I'm going to spend the most time, I think, and title of our presentation is Simplifying Referral Capture. I'll tell you right now, this is not super simple, but it is feasible. And it is, I will reiterate, it is an estimate. So the goal is just to become the best estimate you can possibly have, but you're never going to know exactly what your potential savings is going to be. There's too many factors and variables in place to provide a full solution. So the best thing you can do, this is why I said if you already have a large contract pharmacy network in place, that's best for you, is because you want to look at your non-qualified claims from your TPA. And so your non-qualified claims could also be called your disqualified claims or excluded claims or carved out. I mean, every TPA has a different name for it, but conceptually, it's all of the claims that your TPA is seeing from your contract pharmacies that do not qualify, so they're kicking them out and they're putting them into a big bucket, or I'm doing another analogy, a haystack of data. And so just let's think about how your TPA works for a second. So it takes a claim and it puts a bunch of rules onto this claim to say, is this an eligible claim or not? And let's say there's 10 rules. So your rules are going to be, is this a patient of yours? So they'll look at encounter data. Potentially they're looking at location data as well. They want to know if this is a provider of yours. So they'll look at your provider NPI. Then you have your own rules that you put in place. So are you carve in or carve out? If it's a Medicaid claim and you carve out, then they'll kick that out. Now you have the additional complexity of blocked NDCs. And so it's looking at who is a contract pharmacy, is this an NDC that's being excluded? And so they'll kick those out as well. Depending on your PSA model, is this a brand generic or winners only model? And so those are also reasons why your TPA is going to, if it's running correctly, it's going to kick all of these claims out. If you have 9 of your 10 rules, or I'm thinking like binary, yes, let's do yes, no, 9 of the 10 are yeses, going to kick that one out, right? And that's your TPA is working correctly. And if it only has 1 of the 10 as a yes and the other 9 are no's, it's still going to kick those out into that bucket. And so what the challenge is when people ask, what is my estimated savings? I tell you, well, it's tough because you just have a haystack, a ton of claims that are correctly not qualifying, but your referral capture claims are somewhere in there, right? These are the claims that have 9 yeses and the provider NPI is the no, because this is not your provider and it's working correctly, but you are going to audit it and tell them, well, no, I have justification and auditable records to show that, no, that actually this is our provider due to a referral relationship. So you want to manually qualify that claim and make it that 10th yes. So the challenge is, what do you do? How do you pull those and find those to audit from your haystack of data? If you have 10,000 claims, you're not going to spend all of your time auditing them one by one. So what you have to do, or what I recommend to do, is if you have access to the data from your TPA, export that. We're going to talk Excel talk now. Export that into Excel, put a filter on those, and then filter out the ones that no matter what, would never qualify if it was a referral capture claim. So you want the ones that are 9 yeses and no to the provider NPI. So if you carve out, then kick out all your Medicaid claims. If it's a blocked NDC, that becomes a little more challenging, right? Because then you need to know specific contract pharmacy and the NDC. So we actually have a document that we've shared in the past that if you reach out to myself, or Chelsea Reed is probably the best person, we can provide. It's just a master list of all your NDCs that are being blocked. If you want to do a VLOOKUP off of that NDC to then whatever the NDC is in your TPA data. We have that in, if you've done VLOOKUPs on NDC in the past, you can have 11 digits with or without your dashes or no leading zero. So we have your different options where if you want to look up upon those. So you have to block those NDCs. And then, I recommend if your TPA has a potential savings, you put a filter on just dollar-wise savings. So if it's less than, $100, $200, set your threshold. That's going to kick out the claims that are not worth your time to audit. A generic medication that would potentially save you $5 probably is not worth your time to spend someone on your team or having a consultant audit those claims. So slowly you're decreasing the size of your haystack to try to find those needles. Ideally your goal is to get to a point where a human being can audit a certain number of claims per month and know that this is what your estimate is going to be. And then you already have hopefully potential savings is provided in that TPA data. So that's what your monthly estimate is going to be. And so let's put a real life example in place. Look at your May claims. Let's say you have 10,000 total claims for all your contract pharmacies. If you put the right filters in place, hopefully you can get that down to 100 potential claims. And then let's say just have someone on your team audit 20 claims, count how much time it takes to audit those claims, count what your percent acceptance rate or what percent of those are actual referral capture claims, and then what is the dollar value of that? And then you can extrapolate from there and say, okay, well, it took an hour to do 20 claims. We only captured 1 prescription and the dollar value was blank. And so then, you can move that out to, okay, how do I do all of May and then months moving forward? I will say, hopefully I haven't confused you too much. It is complex, but it's easy, it can be done, and happy to go through that with anybody. And if you work with us, we do that on your behalf. But I will say I haven't, especially if you're a tier 1, or you have eligible primary care and you have a large contract pharmacy network, I have not met a client where it's not worth your time to do so. So using back in my example, if you found 1 claim out of those 20 and it took you 5 minutes to audit that claim, so it took you 1 hour to get through those 20 claims, and your potential savings was $200, then you just made $200 for one person's hour of time. And if you're listening to this call, I assume you probably don't make $200 per hour. And so right there I can show you, okay, well, it's worth your time to do so, right? And keep in mind, this is one fill, and your TPA is then going to hopefully qualify all future refills because you've manually qualified that RX number. And so depending on how often this prescription is filled, then your value becomes increased. If it's filled quarterly, that's $800. If it's monthly, it's even more. So that's your best option, is look at your non-qualified TPA data, filter from there. Two other categories, less useful, but if you don't have TPA data, you can use them. You can look at e-prescribed data from your EMR. It'll be dependent on if you have the e-prescribed data, right? Because if there's a referral capture prescription, ideally this is probably a an independent specialist where you don't have access to their data, so you can ask them for their e-prescribed data if you want to do that. And then you have to put some sort of potential savings estimate upon there, because it's not going to give you the savings. Becomes challenging, but you have that NDC. You could export your wholesaler price catalog and do an estimate based on non-340 price and 340B price, and take out a percentage for what your admin and your dispense fees would be. And then the last category here is referral data from your EMR. So especially if you're looking at what are your hospital referrals going to be, again, you could look at those, export those, and would have to put that 340B price estimate on there as well. Hopefully, if you didn't take any notes, we will have this recorded, and so you can go through those again in the future. So we've been working off of the idea that a referral claim is a referral claim. That's black and white. You audit it and you say yes or no. Is this a referral claim or not? And unfortunately, that is not the case. It's a very gray area. That's probably why a lot of people are listening now. And if you have any questions that are putting in the chat right now, you're probably putting these crazy various situations and scenarios for would this count or would this count? And so our goal of this webinar was not to tell you exactly what a referral capture claim is going to be, because there is no consensus agreement. Like, this is exactly what it should look like. I think it depends on every single covered entity, what your risk stratification is, and how you want to implement this service. And so I'm going to go through a few different examples, and I have 4 bullet points here. There's probably 15 or 20 that you could come up with to say, okay, well, you could do this or you could do this. And I'm going to put a spectrum here of conservative approach to progressive or minimum requirements. If you look at the bottom of the slide, the more conservative you are, think about my analogy again, you're going to have less darts you're throwing at the dartboard, so you're going to have less captured savings, but you're also probably going to have less program risk, right? And then on the flip end, the more prescriptions that you'll allow, because you have less constricting situations in place, more risk you'll have, but more savings you'll have. So let's just go down through this list. I might upset a few folks by not having a definitive answer and saying, yes, do this, and no, don't do this. But I want to just explore the idea, put some thoughts in people's brains and say, okay, what would you do if you were in this situation? So number 1 here is around the responsibility of care. So, conservative approach is saying that the patient has to have been seen by the provider of the covered entity within the last 12 months. But you could also argue and say, well, why did that have to be within the last 12 months? Like, how far out can I say the provider still has responsibility of care? So one of the minimum requirement we put here is last 24 months. So I'm going to pause, and Rob, do you want to explain why I even have the number 24 out there?
Well, I do, but I don't. So good information so far, and I love the risk versus savings kind of graphic as well. But we do like to put it up there because we get that question a lot. Well, is 12 months or should I do 18 months? I've heard 24 months. Just for the record, nothing that was ever published by HRSA or even that we know from Apexis has published really gives a time frame for how long prescriptions are good for, or after a visit from a qualified covered entity, how long's okay. The only place we've ever seen it is in the Morford letter, which is almost 340B urban legend, but I assure you it exists. And if you haven't read the Morford letter, we can get you a copy. Also, if you're a 340B health member, they have a copy in their clients. I won't say what is 340. If you have access, you can access the document. But what the Morford letter really is a conversation between Bill Von Olsen and Thomas Morford, and that was memorialized in this letter. And Thomas Morford, of course, was the deputy director of HRSA at the time. So just a little bit of 340B urban history or legend. And in this letter, Bill Von Olsen asked, and Bill Von Olsen happened to be with 340B Health at the time, and it was SNAPA back then, and asked, well, after a patient seen at a covered entity and that patient follows up with care after the fact, wouldn't that still be qualified? And Deputy Director Morford says, yeah, it would, right, if you read this letter. And then so Bill Von Olsen then asked, well, how long would that be good for? And what's funny is Deputy Director Morford never says how long. All he says is 2 years is too long. well, 2 years would probably be too long. And somehow we've extrapolated 12 months is okay, 18 months okay. Arguably 24 months would be as long as you'd want to go on a continuum of care argument. Referral, I think, is a little different, but you could follow that timeline, or 23 months and 30 days or what have you. So that's where that comes from. But I thought it'd be fun to share kind of this Morford letter thought process. And if you don't have access to 340B Health, we have a copy of the letter as well. So reach out to us. We'll get you a copy. Makes for good bedtime reading. Print it out. Keep it by your bedside for when you're bored and need to go to sleep.
Awesome. Drop. All right, I'll just go through these points 2, 3, and 4 here, and show different sides of the spectrum. So number 2 here is regarding what needs to be in the patient's medical record to show that that the patient's on this medication. So a conservative approach is having the associated diagnosis and the medication in the medication list on a patient's record. You could also argue, minimum requirement is that, at least somewhere that the medication was at least documented. So you don't need the associated diagnosis. Maybe even you don't even need the medication on the medication list, but at least the PCP or provider somewhere in some consult note said, oh, I know that they're seeing, whoever for this drug. Number 3 here is regarding timing of the referral placement, or if you need a referral placed at all. So, document referral to the non-qualified location, so the specialist, precedes medication written date. So that's, your formal referral process. Or on the other end, you could say, well, does the referral need to be placed first? What if the patient self-referred to that specialist? A prescription was written by that specialist, but then you wanted to implement a referral. Like, could you capture the refills after, if the referral is placed after the referral is placed after the medication was written, or do you have to wait for another new prescription to be written? Or do you even need a referral at all, or can you argue continuum of care justification? I'm not going to go into that because I'm sure Rob will talk about it in the next slide. And then the last one here is the closed loop model. Are you requiring that the consult notes come back from that referred specialist provider to then qualify it, or the minimum requirement is just saying it's a one-way referral. We're not requiring that the consult notes come back every single time. Do you think operationally, of course, it's going to decrease your savings because you're going to be waiting to get those consult notes back, and then do you have the time to reach out to that specialist every single time?
Yeah, and rather than the last one, people sometimes ask us, well, what's required? Do you need an actual note from the specialist to come back? And I'd say that's the gold standard, and there was some initial discussions that was true, but I can tell you from the HRSA audits we participate in, what you really have to demonstrate is go back to the patient definition and show that you're still responsible for care. So acknowledging what occurred at that visit in a visit at your own primary care provider's note, talking about the medication and med list, all those things will contribute to you showing that you have responsibility for care regarding that referred specialist visit. So although sometimes you read about having an actual copy of the full visit from that specialist, it's not absolutely required from our experience working with HRSA and qualifying these referral prescriptions during an audit when it was sampled. So just wanted to put that out there because that's a common question that we get. And sorry, Riley, you can go to the next slide.
Very good. Well, I have one more thing to add actually is the one solid recommendation I will give to you, because I gave you just a lot of questions and possibilities. One recommendation I will give is, I put this note here: align your decision with the policies and procedures and standardize your decision and make that consistent every single time you do it. No matter what you choose on the spectrum, I think variation and not sticking with exactly what your policy and procedures saying, not having a standard, is the most risky thing you could do. So that at least is one solid recommendation I'll give you guys.
Document it, then follow it. Okay, so what we wanted to kind of end with here is really talking about the patient definition. So just a bit from, we have a white paper, and we were going to say just email us if you want it, but we actually put it in the webinar. So you should see it as a handout. This is the white paper on patient definition we put out. This is going to give you some information around the Genesis law case, how that might apply to you as an FQHC or as a hospital. Genesis wasn't FQHC. They had some specific things in place. They were primary care. They also had some financial responsibility due to their kind of capitated medical home model that they use, where they're responsible for covering the cost of the drugs and they're coming back to their closed door pharmacy. So, right, sometimes you have to look at, is what occurred in the Genesis law case applicable to me as a hospital? And I would say parts of it are, but not all of it, especially because we have less of those medical home capitated models where we're covering drugs. But I think that white paper will be helpful to talk about 340B patient definition expansion. The second thing we have coming up is number 2. That's a 340B leader panel discussion. So I guess almost preemptively, I'll just share, we've got 2 covered entities actually hopping on a panel discussion with Greg Wilson, Jake Thompson, and myself. And we're talking about this idea of Genesis and expanding patient definition and what that could possibly mean. And I guess what I'll share is kind of the take home with that would be, that if you're going to look at expanding your patient definition, what we like to say is it's going to be short term. And what I mean by this is the fact that even through the experience since 2019 with HRSA audits, we've seen HRSA really not issue findings as often for what maybe prior to 2019 would have been considered diversion. And that's if you can show that you in fact did have a qualified visit with that patient. And then as part of that, what we've been talking about kind of related to the Morford letter or what Riley shared on that spectrum, that you can show that, it was a continuation of care type of visit post. And of course, how long after that's that Morford letter, 2 years is too long type question. But it's really that, would you use this? What's the risk for you as a covered entity? Are you willing to use it? And what we say is, what's interesting is because what we're really saying is HRSA is not enforcing guidance because they don't want to or they can't. You can look at it either way without incurring potential risk for litigation. And so they've basically, I think, been waiting for trying to wait for rulemaking authority. And once they get rulemaking authority, I think they can do some things. So the idea behind expanding your 340B patient definition within the kind of the bounds of legally what you think is appropriate, and every organization is going to have to decide for themselves. So you have the white paper you can read now. In July, we're going to come out with this panel discussion. We've already recorded it. We're just making it pretty and ready for production. And it'll be actually, and just I guess a little hint or up front, we're actually we're gonna start a podcast. It's something we've been excited about, and we're preparing to get that going. We hope to launch it fully, get it started in July, but really talk about it and launch it at the Coalition Conference. So stop by our booth when you're there. We're really excited about it, but this discussion is gonna be really good to help you even understand even more deeply what other covered entities are doing or considering, and kind of our thoughts behind Genesis and expanded patient definition. So we may have some questions around that. We're more than happy to answer those questions, but we wanted to talk about it because I think it's an important part of referral capture. And if we go to the next slide, Riley, we'll tie this into our final slide here before we take questions. It's really this idea of, if you're implementing referral capture, we still recommend it, and here's why. If you do the expanded patient definition, we do think that at some point HRSA gets rulemaking authority. If or when they get rulemaking authority, they'll probably tighten up both the contract pharmacy issue with manufacturers and probably tighten up patient definition along with managed Medicaid and orphan drug, right? All these things that they want to write rules on but don't have the authority to do so today. But when they do that, that means I think we get the contract pharmacy savings back simultaneously while we have to tighten up our patient definition and qualifications. And they're going to have to put it out for rules for comment, and that's typically a 60-day comment period. And once the 60 days are up, then they can finally publish it. So we don't think it'll go retroactive. So we think the risk is low there that you would do something, have to go back in time. But in the meantime, we do think if you're going to do it, do referral capture simultaneously, because that should, at least unless they change that as well, continue on after HRSA gets rulemaking authority and tightens up these kind of loose areas. And so we think there's some positive things you can do with referral capture, getting that all in place, knowing, well, what's qualified, what's not. Because if you purely rely on a continuum of care argument, then you don't know when things change, if that still applies and what qualifies. So it could be a problem. So having good documentation is going to be critical. And we'll kind of just share kind of our service. We want people to know that we have a compliant service. We can do that, or we can just kind of teach your team how to do it. We can do that as well through some consulting. And people ask, well, what's your fee? The fee ranges in the marketplace between 15 and 25%. We felt we wanted to be at the bottom of the market to make sure that covered entities could keep the most savings possible. And then finally, I say Riley's fantastic. He can help you with assessments and opportunities if you just need a little bit more help. And so I'll pause there, Riley, see if you want to add anything else to our services or anything that would benefit our covered entities.
Sure. Yeah, I think bullet points. Well, bullet point 2 is for folks that if you're really worried about compliance, I think who better than a team full of auditors who have done however many hundreds of audits and helped out in HRSA audits to know exactly what should be a compliant referral prescription. But I'm thinking in bullet points 1 and 3, I think are most important. Like for someone like myself, I am no salesman, but I was a hospital leader, and so knowing okay, well, 3 things I think about is how much time is going to cost me and my team? How much effort is it to get some external folks either within my organization or not? And then how much money is this going to cost me up front? I think those are the 3 most important things. And what I was trying to reiterate earlier is it doesn't take much time in operational complexity at all. Like you could feasibly start doing this tomorrow if you knew which claims to audit for. And then at least for us, the fee structure is important because there's no upfront costs. And so the way we've structured it, there's no possible way for you to lose money. it's 15% of net savings. And so, let's go, we sign agreements, we go through the process, I look at your data, I start auditing, I find nothing at all. Well, then all that you're out is, maybe a couple emails and a couple meetings. Like if I don't find any savings for you, then you've paid zero costs. And it's important to point out net savings. So that's, after the 340B costs is taken into consideration, as well as, ensuring replenishment. Depending on your TPA model, you could have a claim accumulate and then you get paid, but then it gets purchased, and so you have a true up in the end. We ensure it's been replenished, so there's really no possible way for you to lose any money on this service, which I know is not the case with contract pharmacy, right? You could have an agreement with a contract pharmacy and there's hidden fees, and you find out, oh, I'm actually been losing money for the last couple of months. We're very transparent there, and no hidden fees. So I think that's great. Yeah.
Perfect. Well, that's the end of what we have. So we'll open up the questions. You have our emails on those slides if you have any questions after the meeting. But Kylie, thank you for moderating for us. And do we have any questions from the webinar on the chat side?
Yeah, thank you, Rob and Riley, for the great information. I'm just going to go through the questions in order. However, attendees, please continue to ask questions on the GoToWebinar panel. Like I said before, if we don't get to your question during this presentation, we will get those answered and posted on LinkedIn next week on the SpendMen page. We are also still getting some questions about the webinars and the slide materials. Those will be available with a follow-up email that will be coming tomorrow. So just keep an eye out for those, and you will get those webinars and slides as well as the patient definition white paper. So let's jump into this Q&A. First question that we have, can we choose any contract pharmacy as our single designated pharmacy, such as chain store, CVS, or Walgreens?
You want that, Riley? You want me?
You can go for it, Rob.
Okay, Riley, correct me if I'm wrong. So yes, in general. So if it's a contract pharmacy, you can. The one caveat is the pharmacy does need to have an HIN. So I think it's a hospital identification number. It costs $100 if they don't have one, and we actually have a little instruction on how to do that. But that's the one caveat. So you can select any contract pharmacy that you want, but you do want to make sure you talk to that pharmacy to make sure that, or the TPA that you're working with. Sometimes you have 2 or 3 TPAs, and some TPAs are better at this than others. So you want to make sure that TPAs have the ability to unblock, right? Some TPAs are automatically blocking these manufacturers. So you want to make sure they can unblock a single contract pharmacy if they're processing multiple ones, that pharmacy has an HIN. What I'll tell you is if you log into the ESP program, so you can actually go into the ESP program, log in, you don't have to select, you don't have to send data or say you are, but you can look at your pharmacies and it'll list all the pharmacies that are available. So ESP's already downloaded those, and you can in there look to see if it's listed. If it's not listed, then you might have to directly work with the ESP program to do that. And I will say there are 2 manufacturers that aren't in the ESP program that you just have to fill out forms for. I want to say it's AstraZeneca and Novo Nordisk. Riley, keep me honest.
Lilly and AstraZeneca.
And Novo.
And Novo too, sure. Novartis is your 40 miles. Novo is your, yeah.
Novartis is 40 miles.
We have a great slide. I'm happy to share for everyone what to do with some. And I didn't take the question first because I feel like there's also one pharmacy that doesn't allow you to do it, but I can't remember. So I'll answer it. We'll answer it again. I'll look it up and I'll answer it next.
BI, I think, or we should have that slide. But anyway, we can give you that slide as well. But just know that there are a couple. Eli Lilly's in ESP, but there is a kind of you have to email them directly for the single contract pharmacy exception. And then AstraZeneca and I think Novo aren't in the ESP program. Novartis is a 40-mile rule. And Riley's right. I want to say it's BI that doesn't allow the single contract pharmacy. So them and Novartis. So it's everyone kind of did their own thing. So, but great question. But the answer is yes. You can, for the most part, do it as long as you can meet the HIN requirement and your TPA can do it.
All right, sounds good. Next question. Should referrals to PCPs be considered, or is it better to exclude those?
Ooh, so would that be, so what I don't know from that question is where the referral is coming from. So is it coming from the hospital at discharge? Is it coming from a specialist? We do know of one vendor out there that is saying that if you have the specialist clinic and they are referred from the primary care provider, so almost backwards, right? So the primary care provider who's non-qualified referred to the specialist, which is qualified, that they're capturing that. And what we say is, going back to our discussion on patient definition expansion, that's not really a referral, or if it is a referral, but it's in the wrong direction, right? The non-qualified primary care is referring to your qualified specialists. And this particular company has said, well, then you can capture all those primary care prescriptions. it doesn't give me a warm and fuzzy feeling, to be honest. And what you really have to rely on is a continuum of care argument. So do you feel comfortable that those prescriptions originating from that non-qualified primary care visit are something that you have responsibility of care for as a covered entity? And what you really want to think about is if this is a HRSA audit and that primary care visit is doing, we'll call it Ambien for sleep, and my specialist is a cardiologist, do I feel good that I can claim that my cardiology visit is going to qualify that? Now, maybe what could be easier is if the patient was in your hospital and was having trouble sleeping and having all these events, and maybe then they went and followed up with their primary care provider. There's that process. But again, we're all talking about probably more continuum of care type arguments than we are a true referral because it's the wrong direction. And so I guess we probably need to know, who the originator of that referral is. But again, your key is think about, do I feel good about claiming responsibility for care during a HRSA audit for the prescription from the non-qualified location? Sorry, Riley, I shared a lot there. Anything to add?
Well, I think you answered maybe a different question, or maybe it was the question asking. I was thinking of like if you're.
My wife says I do that a lot, Riley. She does, yeah.
You're referring from the hospital, which is eligible to an ineligible PCP. Again, like the PCP, in my opinion, probably has responsibility of care has responsibility of care more so than your single hospital, referral visit. So it's going to depend on exactly what the criteria is. But that's how I feel is, it's back to, do you have responsibility of care? Does that specific provider have it or not? So depends is the easy answer.
All right, thank you. Next question. Sometimes the medication itself will not be listed since it's up to the specialist to determine the medication to prescribe, and they may not use the same EMR. If we have an appropriate diagnosis with a referral to a related specialist, but no note on the drug, would HRSA accept this?
You want me to go or you want to take that one?
Our answers are, it's anecdotal evidence, right? Like you want to go through exactly, again, it depends. We have seen anecdotally HRSA is accepting those currently, with the possibly continuum care argument, or just they're not looking exactly into those specifics in that slide that went through. I think it's just good to have those processes in place. And if you don't, let's for example, if you're referring out, and this is kind of answer a question that may be somewhere down the list. If you're referring out to a specialist, you may not, you don't need to specifically be filled by that specialist. It could just be that clinic. And so, it's more of a broad, referring for, cardiology, and whoever at this clinic is, prescribing cardiology medications, that's feasible. And if you don't have the medication on your medication list, one, I think you should do best by the patient and just add that to the medication list. That's something you can document on the back end. It's very simple to do, takes very little time. And so if it's not there, just put it in. If that patient's on the medication, then I think it's responsible to do. But when you refer out, you're not referring for a specific medication, you're referring for the service that they're doing. And so, yeah, I guess my roundabout answer is if it's not there, put it in there, but it also would not be required and probably would pass currently.
I agree 100%. That was going to be my answer. As part of this service, it really should be to update your medical record, right? Think about it as not only you're trying to capture this prescription, but you can also improve the visibility of your primary care providers and what they see. So if you identify, oh my gosh, they're on this medication, then add it to the medication list and have a process for that to keep that medication list up to date.
All right, I think we have time for maybe one or two more questions. So first one, how to capture referral for patient who is seen at provider-based facility, and then all follow-up care and prescriptions are provided and written at private practice. Note that private practice practitioners go between provider-based and private practice.
Yeah, we see this a lot with bigger hospitals and health systems. So that is tricky, right? So again, the question is, we may not be referring to a referral capture, but you might be referring to a specific continuum of care instance where they start at a qualified clinic. And this could happen where the cardiologist is an example I like to use, where they practice 1 day a week at a multi-specialty clinic, qualified 340B eligible clinic as part of the covered entity. The other 4 days a week, they're practicing at their private, which could be related, could be like a medical group or a 190 clinic externally. And so that doctor's going back and forth. And so what I'd say is if they actually have a visit at the qualified clinic, again, you'd have to be comfortable with a continuum of care argument that they were seeing there and for a period of time, and you'd have to define, is it 12 months, is it 18 months, is it 23 months and 30 days? but define that time period and say, we're going to accept that up until that period of time. But if they're not seen again at our clinic, then we're going to say, you know what, our responsibility of care is going to end at some point in this continuum of care type argument. So it can be done, but just know, remember on Riley's spectrum, you're going to go on the more risky side, but you're going to have that opportunity. Anecdotally, we actually had this occur at during a HRSA audit, and it did not get a finding. So it's an N of 1. We probably had more than one of those, but one audit I was part of, it was an N of 1. I thought it might be a finding because this was early on, before we really knew HRSA was going down this road of if you've got a core visit or a qualified visit, then more than likely you'll be okay. So the answer is yes, for the time being, you're probably okay, but do pay attention to when HRSA starts tightening up that patient definition again. Riley?
I have nothing to add. You took up all our time anyways, so I'll leave it there.
You probably got 2 questions if Riley answers one, if I do. Sorry.
Sounds good. Well, thank you guys so much for answering all those questions. Attendees, like I said before, we will answer any of those questions that you did not see answered here on the webinar on LinkedIn, as well as if you have any more questions, Rob and Riley's emails are right there for you. Are there anything else that you guys want to say, Rob and Riley, before we head off?
I mean, I just think if you're interested at all moving forward, happy to send me an email, chat through, how to do a data analysis, or if you just talk about working with us, I'm happy to chat with anybody.
And Riley's the man, and appreciate Kylie moderating. Thank you both.
Kylie, yeah.
Sounds good. Have a great day, everybody. Thank you.
Thanks, everyone.
See you guys.